or virtually. Can I remind everybody this is a meeting held in public? It's not a public meeting, and therefore, unless a question has been received in advance, members of the public are asked to remain in an observing capacity throughout the meeting. I can confirm we have received 3 questions today ahead of the meeting, and these questions will be addressed shortly. Please note this meeting is being recorded, and a copy of the recording will be on the website following our meeting. I do have a number of practical points just to run through before we start. Just to remind those presenting reports to take into account the fact that board members have read the reports. So if there are any updates to those reports, please include them this morning. I'm also aware that a number of our executive colleagues need to attend the Welsh Government's Infrastructure Board meeting this morning. Paul and Gethin will need to leave at approximately 9:30 for about 45 minutes. And Linda is then due to attend, I think, at about 10:15 until about 11 o'clock. So there will be colleagues in and out of the room this morning. And what I might need to do is flex the agenda accordingly if exec colleagues are out of the room at the time at which one of their reports is being discussed. But it's an important investment board meeting, and obviously our interest in that is advancing the development of the Llantrisant Health Park project. That's why exec colleagues do need to be present at that meeting, as well as doubling up and being present in this meeting. We will take a short break at around 11:15, but I'll keep this under review as we go through the agenda. Just to say, I have checked with Paul, and in terms of those matters on the agenda, he's assured he has no particular concern or issues with any of the items that are up for approval, whilst he may not be here. So I've just double checked that with Paul in his role as Chief Executive. I think Rachel and Sally are both joining us virtually. Patsy is online as well. Good morning to you. I would like to also offer a very warm welcome to Hayley Proctor, our new independent member. I say new. Hayley's been in post now since the start of November. It probably feels a lot longer than that, Hayley. But Hayley's our new independent member, trade union. She's attending her first public board meeting today to start in the role. Absolutely fantastic to have you with us. I'm really delighted to see you this morning. A very warm welcome also to Richard Hughes, our Deputy Director of Nursing, who is attending on behalf of Greg Dix, the Executive Director of Nursing and Deputy Chief Executive. And good to see our colleagues from Place Cymru, Kerry and Elizabeth with us as well. Good to see you this morning. Thank you for joining us. As always, I've been advised that we have some colleagues attending online as observers, Paula Cornelius, Donna White, and they're members of staff. So very good to see colleagues joining us online. Just to advise the board that Kelly Andrews from the Royal College of Nursing and a number of our CTM colleagues, so our RCN members, are also observing the board today. And we have 3 in the room with us. Good morning. Nice to see you this morning. And you'll notice there are other colleagues outside watching the proceedings online. Whether in person or joining virtually, everyone's welcome to our board this morning. So it is good to see people engaging in our work. Item 1.2, apologies for absence. If I can just run through those. Carolyn Donoghue, independent member, Greg Dix, Exec Director of Nursing, and Councillor Geraint Hopkins have all given their apologies for absence. Declarations of interest. I don't think anybody's submitted anything in advance. If there's anything now that people need to declare, please do so. No? Okay, thank you. Item 2, the consent agenda. Just to ensure that we focus on the critical activity today, there are a number of matters that are covered off in the consent agenda. Does anybody wish to have anything moved from the consent agenda into the main agenda? Be happy with the structure of today's agenda? Okay, fantastic, thank you. Item 2.1, questions received in advance of the meeting. So just to explain to the board, as you all know, the board is able to accommodate questions from the public up to 3 working days prior to public board meetings. And in order to allow accurate responses, this is encouraged within that particular time frame. So we have received 3 questions in advance of our meeting today. The questions were raised by Kelly Andrews from the Royal College of Nursing on behalf of RCN members working in Clontarf Morgannwg. The Health Board received these questions on the 22nd of November, and we provided responses in writing to those questions raised on the 26th of November. Now, during the meeting held in public, it is practice for questions to be taken and responded to after the completion of all other items on the agenda. However, in light of the interest and the questions raised today, I've decided to address these questions at the beginning of the meeting. I'm also very conscious that today's meeting could well be around 4 hours, and I just thought that was a little unfair to ask colleagues to wait that length of time to hear the answers to the questions posed in a public forum. So hence the reason why I've decided to bring them forward to the start of the meeting. What I'm going to do, because this is being recorded and therefore it will offer a verbal response that will be recorded and put online, I will read the questions received together with the response that has been provided. So the first question that was asked is, are the board members aware of the lack of pay parity between Princess of Wales Hospital, the Royal Glamorgan and Prince Charles Hospitals, and the impact this is causing the staff at Princess of Wales? The response that has been sent back is yes, the board is aware. The board, of course, incorporates both the executive directors and independent members, has been briefed and is fully aware of the different shift patterns which exist at POW compared to RGH and PCH. The board has been apprised of the specifics of the different shift patterns, as well as the fact that POW staff have raised this issue on a number of occasions since the Bridgend boundary change in 2019. The second question that was submitted is, as a result of the damage to the POW roof, are the board prepared to continue to allow POW staff to work alongside colleagues at Royal Glam and Prince Charles, knowing that these staff do not share the same benefits? The response that has been provided is, it is clear that the position with the POW roof and the need for POW staff to work alongside RGH and PCH staff has shone further light on the shift pattern differences. However, it is not appropriate to change shift patterns while the work to understand the benefits of the different shift patterns from a quality and safety and well-being perspective, and prior to any consultation and decision being made. The third question, are the board aware since 2020 several grievances have been raised and nothing has been done by the trust to resolve these concerns, leaving POW staff feeling failed, disrespected and let down by the trust? As stated above, the board is aware that this issue has been raised a number of times since the boundary change in 2010. The Health Board has received 2 formal grievances, one of which was withdrawn, the other of which was not upheld, as the Health Board's position was that the shift patterns, which still exist across Swansea Bay Health Board, were introduced by a fair and appropriate consultation process by the former Abertawe Bro-Morgannwg University Health Board prior to the boundary change, and are protected by the Transfer of Undertakings Protection of Employment, TUPE. We have no further questions to consider today. Members of the public are reminded that should they wish to raise any further questions of the board, then guidance is provided under the Our Board section of the CTM website. And of course, if further questions are submitted following today's board meeting, we will endeavour to ensure that those questions are answered promptly within 7 days. We'll move on to item 3. Just to say to colleagues, we did hope to have a listening and learning story today. I've kept this on the agenda to remind myself to say to you that sadly we've not been able to facilitate that today. The governance team and the patient care and safety team will work to source appropriate stories as we look forward to hearing the next story at our January 2025 I can still say 2025, it doesn't feel as though we're much into 2024. But at our next public board meeting, which of course is in January, we'll ensure that we programme in a new shared listening and learning story for that meeting. But sadly, unforeseen circumstances meant that we couldn't have one today. And right, what I'm going to do is just probably to make it easier for Paul, because I know Paul needs to nip out at 9:30. I'm going to switch things around under the setting the scene. So normally we take the chair's report first along with the action log. I'll do that secondly. So I'll come to the chief exec's report first, just so it frees Paul up promptly at 9:30 to be able to leave. Paul.
Thank you, Chair. Good morning, everybody. Just a few things to draw out from my Chief Exec's report. You'll note in the report the update on our escalation status following the recent tripartite conversations with Welsh Government, and really pleased to say that the CAMS services have been de-escalated by Welsh Government, which is really positive news based on the improvements that has been made in the access times for our child and adolescent mental health services. Really positive news, and clearly there's further work to do because we want to be able to move down further into routine arrangements, but really great news, and we had some very positive feedback from Welsh Government colleagues about the progress that's been made in CAMS since that's happened, so really pleased to see that. You'll note that we still remain in TI for other areas of planned care and cancer and emergency care, and work continues to carry on to deliver against the performance improvement trajectories we've set with Welsh Government, given that's been agreed as part of our annual accountability agreement. So that's really positive news. Also to say that your colleagues will have known that at the end of October, I wrote an accountable officer letter to Jude Paget, Chief Executive of the NHS in Wales, just to highlight the pressures and challenges that had come about following the roof issues at Princess of Wales, and describing the challenging decisions we've had to make on the back of the report that we'd had regarding the roof. There was, since that letter's gone in, that we've had a number of conversations back and forth with Welsh Government about resources to support the capital funding for the roof works, which obviously we received, which is very positive, and also ongoing conversations with them about additional resources needed to restart our elective waiting times, and Gethin will come and touch on that a bit later on when we cover an update on the roof replacement works. Really positive also to see the improvement that have gone on with our cancer services. As you'll know, single cancer pathway performance has been challenging over the past couple of years since COVID, but it's really positive to say that we are still progressing upwards in our trajectory, and our performance, I think most recent performance we've had is nudging the 60% mark now, which is really good, which will be, I think it's the first time, isn't it, since COVID that we've achieved that level of performance, which is really good. And within that, there are some even more impressive performance improvements in certain tumour sites. So really good to see how our cancer performance continues to improve. Obviously, our goal is to get to 70% by the end of the financial year. So hopefully, fingers crossed, we will be able to get there. But really positive to see the hard work that's gone on to get us into that place. In terms of our work on the acute clinical services plan, we've been able to procure additional support. As you know, we've talked about the need to really get our engagement right around our clinical services plan, and the need to make sure that we're engaging actively with our stakeholders on those conversations about how we design our future model of clinical services. We've been able to procure some support from ORS, research services, who are going to work with us to help do the work with our stakeholders to understand how we engage with our stakeholders, how do we make best use and collective knowledge of our stakeholders, and ensure that as we start to develop our proposals, they have been shaped in conjunction with key stakeholders and partner organisations and our community. So really positive that we've got those additional resources and people on board. And also, Linda's in the process of recruiting for the programme director for the clinical services strategy work, which will be hopefully appointed before Christmas, which is also positive. A key part, obviously, of our CTM 2030 strategy is also our approach to how we develop our community services and look at how we develop more out-of-hospital services in our primary care, community services and social care facilities to enable us to manage more people in their own homes and keep people well as long as possible in their own communities. And there's a lot of work going on this agenda. As you'll know, we have Matt Jenkins, who's working on behalf of the Health Board and the 3 local authorities, developing and thinking through how we build our relationship with social services and think about a different model of integrated care, where we look at how we can bring health and social care practitioners much more actively together to support people in their own homes. There's a lot of work going on that Matt has been working on with colleagues in the local authorities and our own community services teams particularly around urgent response and how we respond when people are in a crisis situation. How do we make sure that that integrated approach is as effective as possible? And also how we develop and plan our more proactive approach in population health management, so that actually we can get ahead of the curve and try and anticipate people who may be at risk of deterioration and work with our health and social care teams to proactively manage those people. Matt's also been working on the architecture that needs to sit around that integrated care. So thinking about what do the governance structures between health and social services need to look like. And there is an MOU being developed between ourselves and the 3 local authorities, which is due to come some point today.
Yeah.
Yes, it's here. So Matt will be able to talk that through in a bit more detail, and also the potential development of further into a further Section 33 agreement for this opportunity to sort of run more pooled budgets and integrated teams across health and social care. So really good to see that that work's progressing. There's a lot to do, as always these things. There's a lot of detail to be worked through, but Matt will be able to explain a bit more of that later on today. Also really positive to report that we continue to run our SEREN staff engagement and staff recognition awards. We have continue to see a high number of colleagues nominating their colleagues for SEREN of the month. And we've had 2 winners since the last board meeting. Natasha, our head of engagement, was our August winner, who is doing some fantastic work on engagement generally, but also particularly was all the work she's done in helping support the health board preparations for the Eisteddfod in Pontypridd this year. As you all know, we had a large presence at the Eisteddfod with a range of teams from across the health board part of that event, and a great opportunity to engage our communities in a number of health and wellbeing discussions. And also in September, Haisam, one of our clinical fellows in paediatrics, was nominated for the support he gives to other colleagues on their training journey, and I was really pleased to go and present him with his award up at Prince Charles Hospital last week. So really great to see the continued range of colleagues who are being nominated, and really does reflect the diversity of the workforce and roles that we have across the health board, and a really nice way to be able to recognise our colleagues on a regular basis. That was all I had to say, Chair, from my mind.
Thank you, Paul. Okay, can I ask, do colleagues have any questions to Paul on his report? I can Lisa and then to Kath. Yeah.
Just on the CAMS, really positive that that's de-escalated, because obviously that's a concern for local authorities. I'm obviously conscious there's been an inspection recently with regards to CAMS nationally. So are the health board in the process of developing a plan around that, and sort of will we see that as the health board?
Yeah. So that the work that's been done nationally is going to be picked up by our local teams clearly. So we'll be benchmarking where we are against the recommendations that have come out of that report. Happy to bring it back here, or indeed whether we take it back through the children's board or somewhere like that might be quite good to make sure we've got that multi-agency oversight of that plan. But the CAMS team will be picking that up.
Thanks.
Yeah, I was going to comment to say great work from the CAMS team, so I think we can pass that on to them around that. So really pleased to see that. I think the MOU was really exciting, and I think the integrated approach is the way to go, and we need to be working much closer with our local authorities, sort of members. And I'd just like to sort of understand our level of ambition around integrated budgets and sort of single approach to workforce, for example. And how ambitious are we going to be as a health board around that real integrated sort of model? And I also wanted to also mention mental health. I was at the Maritime Resource Centre yesterday, looking at the older people's mental health services, and I've also looked at Bridgend integrated services. And I guess it's around how do we make sure that as we move forward, we're taking the lessons learned and the best of whatever region is doing. You know, how do we take that forward? So that was the other question really around the integrated model.
Yeah, no, absolutely. We had the adults board yesterday, sort of day before yesterday, and we talked with Matt about this, and particularly learning from the experience that we've already got, because as you rightly say, we've got lots of different examples across our patch of integrated working across health and social care, and there's experience that colleagues have of what works and what doesn't work. We touched on one of the learnings, which Stu won't be surprised to learn, was about how we make sure that records can be shared as much as possible between health and social care professionals, because that's often one of the big barriers to enabling joint working. So absolutely, we want to learn from the good practice and ideas that people have already got. I think in terms of the scale of the ambition, I think absolutely we need to have big ambitions on it. I think we also need to recognise, however, we are all in different places, we're start at different starting points. So I think there's something about how we sort of have a programme of where we want to get to, but sort of stage it in a way that sort of enables us to start. So I think the focus we've got on starting with sort of urgent response, looking at how we improve the integration of urgent responses from health and social care, and then also that proactive case management. But we also talked about other areas of work and opportunity that we could start to develop. So Matt is helping bring that to the table. But I think also to your point, Kath, it's also about the enabling architecture. So whether it's digital, whether it's budgets, whether it's estate shared facilities, whether it's about shared workforce, those are all things that we need to sort of be developing as work streams under this programme of work, because they're all the real critical enablers that often stop these sorts of integrated arrangements from functioning effectively. So we also talked quite a lot at the adults board this week about the need for that wider cultural change and organisation development. Because, you know, my experience of these things, it's all a good thing. You just put people in a room together, but you've got to actually spend the time and effort with those people to sort of, you know, it's about cultural long-standing perceptions of how different professionals work and things. So we've got to think, I think, carefully about how we invest in capacity to run that sort of OD programme as much as the technical side as well.
Is that okay? Thanks, Chair. And just to add on to what Paul's saying around digital provision. So, and Lisa will know this because we've already got a set of digital regional working board now. Clearly, it's focused on some specifics around that connecting care, you know, approach. But actually, the work we're doing with BCU on mental health as well, which is really positive. We haven't had any official notification from Welsh Government yet, but it is looking really positive in terms of our business case that was submitted. So I'm hopeful. And Paul and I are meeting with Sarah Murphy, the MS, later this afternoon. So I'm hopeful we'll get some more clarification on when we'll actually get our funding for that. But the broader piece, actually, in terms of opportunities to work with digital colleagues from local authorities as well, because, you know, there are lots of things where we are, you know, they are fairly sort of common sort of solutions, if you like, if you think about Microsoft platforms and things like that. So we are looking at those opportunities as well, just to assure you.
Just go back to the memorandum of understanding. Obviously, the document is an appendix to Paul's report that does require approval of the board. Linda, do you want to come at this point on the MOU?
Just to formally ask the board to approve the signing of that MOU, which essentially is a statement of intent, isn't it, to work on bringing together the agreements we've got under a single Section 33 and provide a mechanism by which we can add into that as we develop our approach to joint working and joint delivery of services with local authorities. So as we understand it, it's going through various cabinets, and will be signed off there. So seeking approval here, please.
Thanks, Linda. Can I say, I mean, you know, for many people reading it, they might think, not reading the MOU, but just reading the context of this, you might think it all sounds a bit sort of legalistic and a bit dull. No offence to lawyers, a bit technical. But you know, Section 33 of the Social Services and Wellbeing Act, I think, is probably a little used bit of the legislation that's actually hugely impactful if it is used, because it is around bringing together that shared, integrated approach, and, you know, pulling partners together in and providing a framework within which people can do things in a more integrated fashion. And we know that public bodies, for one reason or another, have probably struggled in this space over the years. And I don't know whether any other part of Wales is using this bit of the legislation to help enable and support that integrated approach. So I think this is really exciting, actually. I mean, once you get beyond the technicality of what it is into the reality of getting people to work far more closely together in planning and delivery of our services, because we know that all those people out there don't really care, and nor should they care, quite frankly, as to whether, you know, one individual is employed by one organisation or whether they're employed by a different organisation. In fact, people in receipt of care want to know they're just getting the best care available to them, and they're not having multiple conversations with several different people about all the challenges they face. So, you know, we could be better at doing this, and I think this is a fantastic opportunity. You know, and I pay tribute to our colleagues in the 3 local authorities who I know have been, you know, really supportive of the work that Matt Jenkins and the team have led, and have done this at quite a significant pace. So yeah, thanks, Linda, and really appreciate that. Any other question to Paul on his report? No, okay. Well, Linda's put the proposal to the board that we approve the memorandum of understanding. Can I ask colleagues to approve the MOU? Yeah, there are no objections, I'm assuming. Okay, terrific, thank you very much, and we'll note for support. Okay, right, just so, no problem at all.
And sorry,
Okay.
Jonathan, I'm going to.
You need to go as well. That's fine. Yeah, no problem. Thanks, Linda. We'll see you shortly. Okay, we'll return to the chair's report. Fairly self-explanatory. I just want to draw out one particular section of the report, which is in respect of the board development session that we will be holding in December. I said earlier that 2025 is rapidly approaching, and that means that we need to be doing some of that planning and thinking work around our priorities for our budget for April 2025 onwards. So that means that we will spend time in our board development session looking at what we said we would deliver this year and how well we delivered it. What are the things that we want to focus our resources on from April next year? We know there's some big ticket items that we need to be delivering around that radical transformation in digital and use of data. We know we want to be better in the prevention space and investing more of our resources around delivering that community care system that will help keep people as well and safe for as long as possible and reducing the chances of people needing hospital care. We know we're talking around what the shape of primary care looks like in the future. So we've got to start, I think, setting out some of these ideas, in quite a broad way in December. And I'm looking forward to that conversation. At the same time, and linked to that, we'll have an update and hopefully a facilitated discussion around developing our primary care system. Because we know there are huge challenges in primary care. It's one of the greatest concerns that the public have. When you talk to them, that people cannot get to see or struggle to get to see a GP. We know that there are challenges in primary care that we need to be addressing. And whilst there are those things that sit very much within the GMS contract for which government is responsible, there are things for which we are responsible as a health board in terms of that community care planning opportunity. So I want us to use that session to also start thinking about what does the shape of primary and community care start to look like, knowing all the other stuff we're doing around the integrated care system with local government, knowing we're doing the hospital at home scheme through the recruitment of healthcare support workers to get people out of hospital. The direction of travel needs to be back towards where people live. So I want us to use some of that time in order to try and shape that out with a bit more clarity. So I think that's really exciting. There's nothing else to update in terms of my report, except to point out but since we last met, there have been quite a large number of documents that I've signed along with the Chief Exec on behalf of the Health Board to affix the use of the Common Seal. And there have been a number of items of Chair's urgent action. There have been two in respect of the Module 10 of the COVID-19 UK Public Inquiry, which we did seek approval of board prior to me taking that decision. And we also needed to take decision as the board in respect of the the legal route has now been taken, the judicial review has now been taken in respect of the ambulance service. So that we had that one recently as well. So that was in respect to the judicial review that's been launched by groups who have been concerned at the outcome and the process in respect of that decision. And I took a decision recently around that. So there have been a number of areas where we've needed to take decisions, of which they are detailed in the note. And what I would ask the board, just to double check, are there any questions on my report? Or for self-explanatory. Okay. Just in terms of any points of clarification or questions on the Chair's urgent actions that have been taken. Anything on those? No. Okay. Just want to check. Therefore, is the board happy to note the report and also endorse the use of the Common Seal and approve the various Chair's urgent actions that have been taken? Yeah. Okay. Fantastic. Thank you very much. Okay, we'll move on to the action log from the previous board meeting. There are a number of areas that have now been completed and proposed for closure. There are a number of items that are still in progress, and they've been detailed in the final column of the report. Any questions to the team in respect to the action log? No, all content. Okay, thank you very much. We shall note the action log. Right, we'll move on to the next item, which is going to be the update report on the Princess of Wales Hospital. We're going to delay that because I'd like Gethin and Paul and Sally in the room for that discussion. Following the need to replace the roof at POW, obviously I felt it was important that the board at the earliest opportunity in public forum should have an opportunity to discuss a range of matters in respect to that. We'll come back to it when our colleagues are back in the room, but it was important to have this on the agenda this morning. So we'll come back to that one. What we'll do now is if we can just come to the board, committee and advisory group highlights reports. I think it would just be useful just to deal with those matters first, and then we'll return to 5.1 as we are able to. So we've got the first one is the Charitable Funds Committee highlight report. Ian, you're the board lead for this this particular item. I'm just wondering, in terms of the committee highlight report, there was a report from the 23rd of October, which is in front of colleagues. Any updates to that report, Ian, or anything like that?
No updates. I just wanted to point out the positive escalation issue on that, because this was a delight, to be honest, discussing this at that particular meeting. It's enabled us to purchase some new equipment to do glaucoma work within my stake hospital, and that is going to have a great effect. That, together with the business plan, which people can look at on the online documents, will enable us to eliminate the glaucoma waiting lists within 11 months, which is a tremendous thing, because we all know we've had issues in this area for quite a while now, and so it was a delight that we could actually pass that in the meeting. So I wanted to highlight that to everyone. And the other thing on there was just to advise people that we did defer one item, just in case you're wondering that. It was a proposal to appoint a new arts manager, but there were some things to do with the proposal that we wanted more clarification on. So we deferred that. So we've gone back to the people who are requesting that. So that will come back in the future. That's all I wanted to raise.
Thank you, that's really helpful. Any questions to Ian on that? But really good to get that update. That's great news. Terrific. Thank you. Thanks, Ian. Okay. The next item is the stakeholder reference group highlights report of the 15th of November. And Anne, I know you chair the stakeholder reference group. Anything you want to highlight to the board in respect of the committee report? Thank you.
Yeah, there's a mistake on the highlight report. The last paragraph of the third representative is a copy and paste error, so that needs to be taken out of the report.
Okay.
And really it's just to ask but 3 new nominations for members of the stakeholder reference group. They were endorsed at the last meeting, and it's just for board approval for the 3 new members in the report.
Okay, that's great. Thank you very much. Thanks, Anne. Can the board obviously just note the update and approve the 3 new member nominations outlined in the report? Yeah, okay, thank you. That's terrific. Thank you very much. Appreciate it. As always, we keep the escalation status update on the report. There's nothing further I want to raise under this item that hasn't already been covered in the Chief Exec's report. Do colleagues have anything they want to flag at this point? No? Okay, thank you. Right. Next item is the board assurance framework, and I'm going to ask Gareth to present the assurance framework update report. It's been endorsed. It was endorsed by the Executive Leadership Board on the 11th of November, and it's before the board this morning for approval. Thank you, Gareth.
Yeah, thanks, John, and good morning, everybody. This is the regular report, obviously, we bring to every board meeting. Before I go into the changes to risks during this period, I just want to mention the format and structure of the report. The board assurance framework, obviously, at the last board meeting when we met at the end of September, there were some comments around the length of the board assurance framework, which we've taken on board, and just want to record my thanks to Callie Hamlin in my team, really, for the work that she's done to sort of refine how the board assurance framework looks and improve the flow of the information within it. because we were cognizant as well, it was becoming quite a lengthy document as it's evolved over the last couple of years. So grateful for any feedback members may have on how it's now looking, and obviously going forward as we look to support the board in different and more effective ways in the new calendar year. We've got new committee structure, etc. The board assurance framework will increasingly become a really important strategic tool in planning our agendas and our priorities, both as a board and as the committee. So just to set that context in terms of how we're going to be using this board assurance framework going forward, and very much in mind as a dynamic document. In terms of our risk profile and the strategic risks our board faces, clearly the critical incident at Princess of Wales Hospital in Bridgend has had an impact on our risk profile in the period, and a direct impact in terms of certainly strategic risk 1A, as you can see from the paper and the supporting information in Appendix 1. It's also unfortunately delayed the crafting of the estates risk, which is referenced in the paper, because clearly the capital and estates team have been primarily focused on resolving the issues at the Princess of Wales Hospital, but we are cognizant of the importance of developing that risk as well. So just to set that context for you. There's also an increase in risk around our potential failure to manage revenue resources within the revenue resource limits. So I'm sure Sally will say a bit more about that later on when she presents her finance report, recognising the pressures the health board's facing, particularly around our savings targets in year. And I'm sure that Sally, as I say, will provide that greater context. And just to note as well that the people team have undertaken a thorough review of the number of risks which they are responsible for, strategic risks 3, 6 and 7. So just to set that context really, Chair, in terms of both the format of the report and the changes in risks in this period. But obviously all of this is underpinned by the wider risk management strategy, and subcommittees of the board obviously see the risks from the organisational register pertinent to them on a regular basis as well. So I'll just go back to you then, Chair, for any questions.
Thanks, Gareth. That's really helpful. Any questions to Gareth on the board assurance?
Just a comment really, just to say thank you. I think it's a really helpful document and shows as we go through particularly critical incidents that we are able to reflect that in the insurance framework. I was going to ask about capital estates, but you've already covered that, Gareth. So I really appreciate all the work that's going on around that. But hopefully next time we can see that risk evolving. Yeah. Thank you.
Thanks, Sam.
Thank you. Any other questions to Gareth? Okay. The colleagues happy to approve the board assurance framework? Yeah. Thank you very much. And certainly welcome the fact that we've obviously rightly covered the changes in the risk profile. But yeah, some of that we'll come back to it as we discuss the Princess of Wales Hospital a little later. We're going to skip the planning maturity matrix because Linda is out of the room, so we will return to that one, which brings us on to the Director of Public Health's annual report, which into diabetes. Thank you, Philip.
Thank you very much, Chair, and thanks very much for having me. I'm going to spoke to many of you about this anyway, so I won't labour the points. And you're asked to approve the report, but in reality, we're asking for more long-term support for this vast body of work, really. So, I mean, just to recap, between 2009 and 2022, diabetes prevalence increased by 40% across Wales. And it's estimated that by 2035, treating complications from diabetes will cost approximately 17% of the NHS budget. So this is a huge burning issue. And clearly linked to that, we are seeing and we will continue to see increases both in morbidity, ill health and mortality, unnecessary death from this as well. 90% of the diabetes that we're seeing is type 2 diabetes, which means that the risk factors are modifiable, which means that we can prevent this as well, or we can go some way to preventing it. And clearly in various fora, we would have heard about the National Tackling Diabetes Together programme and the fact that CTM is taking a real lead in that work, especially through behavioural insights work. So we've got a lot to be proud of within the CTM, but we've also got a lot to be concerned about as well. CTM has the second highest prevalence of diabetes in Wales at 8.6%. We've got 68% of our population who are overweight or obese, and some of the highest rates of childhood overweight and obesity in Europe, frankly. We've also got really high rates of inequality. That's both in terms of risk factors and also in terms of access to services. So clearly, that's clearly a priority for the health board. I'm not going to labour what's in the report, but there are many ways in which we can prevent this coming storm. Both primary prevention, stopping the risk factors, secondary prevention, addressing the risk factors, and tertiary prevention in terms of stopping people who have diabetes from developing complications, becoming ill. But clearly, we've got a load of challenges as well. And many of the challenges that are faced by the population with regards to diabetes sit outside the immediate sphere of influence of the health board. So Wales is an obesogenic environment. I mean, we just have to drive past the fast food shops on the way to Keir Hardie Health Park, for example. Clearly, there's ongoing issues with regards to sustainable funding for prevention. We also have relatively low awareness of diabetes and what its effects can be. And we know, looking at care, we have care that's working in silos, there's duplication, etc. So there's a lot of work that is ongoing and that's detailed within the report. In terms of the next steps, CTM is in the process of developing a 3-year strategic plan across public health, across clinical services. But obviously, we've got that dilemma of balancing management of people who are currently have diabetes and complications from diabetes with that preventative aspect as well. We need a universal proportionate approach with those evidence-based pathways, workforce development, and hopefully communications as well, both internal and external. Lots of work's going into it. We have national and local co-working implementation. A whole system approach to healthy weight is developing. We will be talking at length about the expansion of the weight management service, both for adults and for children and young people. And a lot of work is underway in terms of how we increase awareness and maximise on our expertise in terms of behavioural insights. So, as I say, I'm asking the health board to approve the report, but critically, I'm asking for your ongoing support as well. Thank you for that. Thank you. Tom.
Sorry, I wonder if you can hear me.
Hi, Tom's lost his voice, so he's going to try and. I did say bring some cue cards for the text on it.
Kath wants me to do this in mine, but I'm not going to manage this. Just to back up what Philip said, we cannot underestimate the amount of diabetes at CTM. It is probably, in my opinion, Philip and I co-chair the diabetes group internally. It's probably the biggest problem that we generally have when you bring in the fact that it has overweight aspects into it as well. It's podiatry, ophthalmology, everything that when it comes to do something in this area. And the obesity overweight system we have is the capacity that we have to deliver to the moment and is funded centrally. It doesn't even really scratch the surface. And you can see that from the bills we have to fill all our stage 4 category 4s to Stormzy Bay, who virtually closed their books for the last few years because there's nothing they can do about bariatric surgery because the sheer numbers. So yeah, the other area that we need to really look at is transition care. But we've got very, very good paediatric care in diabetes, but they tend to be more type 1 because type 2 isn't that big, type 2 being the insulin resistant sort of variety. And that is increasing massively. But we need to get that transition right between the childhood care and supporting them as they go on to become the teenagers and the adults that they are, to live their lives and take control of it themselves. And that's the real danger period. So, echoing everything Chris said, we really focus in this area. That's done.
Yeah, just building on that. So, completely agree. I think it's a big risk for us, particularly within CTM, but across Wales. So, you can see in the performance dashboard what our weights are for children's dietetic service, which is a small specialist provision. There is some joined up work starting to happen across Wales, isn't there? So each of the clinical exec peer group forums are coming together now and have set a shared priority. Diabetes, obesity is one of them. But the challenge is there's only so much that's in our gift. So that joined up whole system approach is absolutely key. But yeah, big concern.
Any questions to Philip or comments here to this? Thank you.
It's not a question, it's more a comment.
Yeah.
It's about recognising how much the third sector can help you deliver on this plan, because the third sector deal directly with, there's loads of programmes on healthy eating, on teaching people to cook, etc. And you need to get in there and work with the third sector to get your messages across. They're more likely to listen to somebody in the community than yourself, with respect. But I don't underestimate how much the third sector can help you deliver this plan.
I was speaking to the Getting There Foundation about it yesterday, for example, and obviously the work they're doing around healthy eating, etc. Really keen to support.
I said earlier that we, as we get into December and our board development session, clearly we want to think about those things that we have to prioritise. I sit in lots of meetings where I talk about the public health challenges in this health board region, but knowing full well that we don't have a comprehensive weight management service. So on the one hand, I feel somewhat hypocritical when I talk about the risks and the threats and why we're not doing more about it. I'm afraid that is an area that we'll have to prioritise. Okay, and I think we are duty bound to ensure that we're doing everything possible to to help people to be as healthy as they can, notwithstanding the fact that there is a lot, as Lauren rightly said, it is outside of our direct control. There's a lot that we can do. We know lots of people will end up in GP surgeries who are pre-diabetic. What are we doing to ensure that at primary care level we are doing more to help people reverse that diabetes position and improve their blood glucose levels? However, there is a big system challenge here, and government has to be in the driving seat with much of this. I've been around long enough to remember the debate on banning smoking in enclosed public places, and we did it because it was a first-class public health measure to address not just the levels of smoking, but the risks of secondhand inhalation of smoke. We have to approach this with the same sort of radical attitude, if I'm being honest. We have communities that are blighted with, I'm afraid, awful choices, or rather no choices in front of them when it comes to what people eat and how people live their lives. We know that processed foods and ultra processed foods are highly addictive, and it's usually those people with more limited means who end up in that cycle of sadly not being able to make a different choice. We've got to start addressing this at a big system level. So I think, Philip, going back to your other role as being chair of the Faculty of Public Health, that opportunity to advise, to speak truth to power, in government, as well as thinking through a really thoughtful plan. I think it's drawn out in this report of the things that we can do at a practical level, working with our third sector partners, where there's a huge amount of opportunity to help people. And it's a difficult conversation to have with people about lifestyles and the older you get, no one likes being told what to do. I don't. Just ask my wife. And so it is hard. It's really hard to have a conversation sometimes with people, but there are practical things we can do. That research piece that was highlighted at the CTM R&D conference on Tuesday around tackling diabetes was a really good example. Some really good data and information there about some of the practical steps that could be taken to help people to address this particular challenge. So we've got to hit this with full force. It's a great report, by the way. It really is fantastic.
And I mean, huge thanks to the team involved in it again.
Okay, thanks. Okay, we will now go on to the annual presentation of our nurse staffing levels. This is something that falls under the legislation that was passed by the then Assembly some years ago, and as a consequence, we are. It's really useful to the board actually to get this update in annual form. We get other regular updates as well from Greg as our Director of Nursing, but this is our annual presentation of our nurse staffing levels. I'm delighted to invite Richard to present the report, which the board has been asked to note.
Thanks very much, Chair. Noting that we have a couple of new board members, I'm wondering if I can just take a moment to go through what the process is in relation to nurse staffing. So essentially the Act has two components to it, namely section 25A and 25B. 25A is the requirement for us as a health board to look at the planning and recruitment strategies in relation to nurse staffing. It's 25B that mandates the calculated element of nursing staffing levels to specific inpatient wards. using a prescribed methodology. So I won't necessarily go into detail in relation to 25A, but I've just given you the oversight that we need to have a focus on that, but it's not so prescribed. In relation to 25B, we need to take into consideration a number of elements. So from that, we look at medical inpatient wards, surgical inpatient wards, and those were the two original elements. And later in 2021, that was extended to paediatrics. The methodology, of course, will include a degree of professional judgment, and that's where conversations with myself, with Greg as the Executive Director of Nursing, as well as care group directors, will come into play. There's an evidence base to this as well in relation to the workforce planning, consideration around well-being and safety outcomes. So looking at measurability in relation to incidences, pressure damage, falls. We've got to do this on a biannual basis. That's something that we're subscribed to in order to review any subsequent changes across the wards. And of course, then during this process, we triangulate the data that we've got, the intelligence that we've got, in order to reach an outcome, and then go through an approval process, which of course involves the Executive Director of Nursing. This, of course, then will eventually come to you as a board for noting and for consideration, and just the assurance element. There's ongoing monitoring in terms of incidences being reported and that biannual review. So for the September report in particular, there are 17 acute medical inpatient wards, 16 acute surgical inpatient wards, and 3 paediatric inpatient wards. It's worth noting that during the reporting period, one ward was repurposed from medical to surgical, and that was Ward 16 in POW. I will state at this point as well, it's worth noting that since this report and the reporting period, there have been a number of changes in relation to the POW makeup, owing to the incident in relation to the roof, as we know. But this reports the period that we just spent. So the report indicates that following the June 24 acuity audit, there were discussions regarding establishment levels, and you might see some adjustments there in relation to particularly healthcare support worker. So that was tailored to the data and everything I've described to you in relation to the intelligence around falls, pressure ulcers, and acuity overall on the wards. Those discussions were involving care group nurse directors, their relevant finance partners, and their workforce partners as well. The review process considered several factors such as patient acuity data, nurse-sensitive quality indicators such as those I've mentioned around falls, pressure ulcers, and medication errors. Within paediatrics, we also look at those children who require transfer to tertiary centres. That will also inform our approach. There was, of course, then professional judgment and financial implications. Chair, I'd like at this stage to stop and take any questions. Support would have been read. Yes, thank you very much.
Thank you, Richard. Terrific. Any questions to Richard on the report? A lot of interesting data. Patsy?
Yes, thanks, Richard. Just a quick question on the financial impact. Sorry, my throat's not very good either, Tom. I'm in sympathy with you. The table in paragraph 4 talks about proposed uplifts and goes through a series of figures and different wards. Yet in paragraph 7 on the recommendation, it states note the changes. Should the recommendation be note the required changes, or have those changes been made? The two areas seem to contradict each other.
Yeah, I know that, Patsy, and that should the required changes, because the discussion that was had in relation to any changes following review with individual care groups, that they were to go back and look at how that was going to be financed through their care group budgets. So the required changes would be the correct terminology.
Thank you, Richard.
Thanks, Patsy. I hope you're feeling okay. I know that, yes, but thanks for being with us this morning. Any questions to Richard? Just to say, for colleagues' awareness, the legislation applies in a very specific way to certain inpatient wards and hospitals. There has been quite a significant campaign led by RCN Wales to have the legislation extended into other areas. And I know there's been broad support actually in government ministers to do that, but that hasn't happened as of yet. Is there any sort of likelihood of that happening in the short term review?
Yeah, so we are currently working through, so we utilise a system called SafeCare. That's how we use a lot of data in relation to staffing. And so with that being introduced into paediatrics, that's allowed us to then adhere to the Act. We are now looking at areas such as mental health in relation to SafeCare as well, which will then, we expect potentially to come online, mental health aspects to the Act. That said, that needs a lot of consideration. It's a very, very different landscape, clinical scenario. And I know that Anna and other specialists will be involved in those conversations. Thanks, Richard.
Yeah, okay, terrific. Okay, sorry, Harold.
Yeah, I suppose just to raise a question, just because conscious Sally's out of the room around budget approvals because of the uplift. So what's our process on that, I guess?
Yeah, so so where there's been the requirement for uplift, particularly into the healthcare support workers, essentially the nurse directors have been asked to go back to their care groups, the service directors and the finance partners to look at how that could be resourced financially. And so you might note in some of the lines, particularly referring to unscheduled care, it's been listed as an investor save element based on the reconfigurations within there. So that's part of the information that comes out at the end after we do the qualitative elements in relation to looking at the particular measures around patient safety and quality.
So essentially part of care groups funds then to accommodate that business stuff. Thank you.
Right. So just to explain to the board what we're going to do next, because some of this has been shifting around a little bit this morning, and it will continue to shift for the remainder of the board meeting. Because every other item on the agenda requires Sally, Gethin, Linda and Paul to be back in the room, either for all of it or for bits of it. What I'm going to do now is bring forward the last item, which is the consent item, just so we've discharged that. So the consent item has a number of things for approval, so that those matters contained at 8.1.1 down to 8.1.6. Can I ask the board to approve those items that are listed in the consent item? Yep, thank you very much. And just to note for the record, item 8.2. Anyway, it's the so 8.2.1 down to 8.2.7. Those items for noting, which includes our cycle of business work programme, highlight reports, along with the clinical education annual report, the CTM Regional Partnerships Board annual report, Public Services Board update, and NHS Wales Shared Services Partnerships Committee assurance report. So all those items are just for noting for today. Now, as I'm unable to deal with any other item on the agenda at this point, because of our colleagues attending the investment board, we are now going to take a break, and we will return when we're able to do so, because finance matters, performance issues, Princess of Wales Hospital, and the capital programme update as well, all of which require those 4 members of the exec team to be back with us. So just coming up to 10 o'clock, we will now take a break, and we will return when we're able to do so. Thank you very much. break. As colleagues will know, some of the agendas moved around a bit this morning to accommodate other very important meetings been taking place. What I'm going to do now, just to get back to those matters that need to be dealt with. I said at the start that we would have an update report on the Princess of Wales Hospital. Can I just say, you know, this report's really important. I think it's the time really for the board to be able to discuss how we found ourselves in the position where the work on the roof needed to be commissioned, the way in which colleagues have worked incredibly hard to address what was a very worrying and risky situation for patients, families, and of course for staff, and also for the board to reflect on the range of changes, of service changes that our executive team and their teams and our staff have needed to lead and deliver in order to accommodate the fact that many people need to be moved out of the Princess of Wales Hospital. This has been a hugely significant piece of work for the Health Board to deliver, and I'll ask Gethin and Sally in a moment to present the report. What I will say is that, you know, as we note this report, and you know, the report does highlight the operational challenges. It outlines the response, I think, in some detail to those challenges, and it also sets out the funding and business case background to this. But in the first instance, I just want to thank the entirety of the executive team, and particularly Gethin and Sally, who I know have done a huge amount here in terms of having to rearrange services and sort out the finances. But this is also a thank you from the board to all of our staff who I know have really stepped up. We've asked people to work out of different locations, and people have got stuck in. They really have. And I just want to say a heartfelt thank you to all of those staff by now who really have done the right thing, and you know, by their patience. So thank you to them. Am I going to come to Sally first or to Gethin?
I think I'll go first,
Gethin?
and then
Sally. Yeah.
hand over to Sally.
Thanks, Gethin.
So, as the paper outlines, you know, we had a period of significant water ingress in September. On the back of that, a significant structural survey of the roof identified some serious issues regarding the integrity of the roof. On the phase 1 element of Princess of Wales. So POW was built in 3 phases. Phase 1 was the original phase. As you will see from the paper, that area that covered a significant proportion of the core clinical estate for the cloud. So it included the 6 main theatres, it included the intensive care unit, the endoscopy unit, the labour ward and the obstetric and neonatal facilities, and 200 beds. So that's around 2/3 of the bed stock of Princess of Wales. So, you know, a significant chunk of our core clinical estate. When we understood the level of risk associated with the roof, it was we had to undertake a prompt and safe decant of the first floor of phase 1. And so that was an EPRR response was set up. We had gold, silver, bronze arrangements across the health board to deliver that programme. What that has meant is that we have had to move a significant number of patients out, and we have had to reconfigure the estate within Princess of Wales. So that has included moving the intensive care unit downstairs into the eye surgery unit. We've changed the designation of a number of our wards deliberately so that we could continue to run an emergency department at Princess of Wales site. And so that resulted in maintaining, or the focus to maintain, acute medicine and the associated subspecialties for acute medicine on that site. So we have seen significant change to our trauma service. So our trauma service now diverts to the Royal Glamorgan, our stroke services diverting to the Royal Glamorgan. A proportion of our medical and surgical takes have both been diverted to the Royal Glamorgan in order to manage a demand to ensure that we've got a bed stock at Princess of Wales that can support the emergency department but continue to deliver ambulatory care to the population of Bridgend from their local hospital. The maternity neonatal service, of course, was already displaced up to Prince Charles at this point because of the ongoing electrical work. So we haven't had to move that service, but it has resulted in a delay of the return of that service to the Bridgend site. We have opened additional beds on the Royal Glamorgan site at Ysbyty George Thomas up in Treorchy and at the Angelson Clinic at Glanreed. We have, but that still leaves us with a net loss of around 75 beds across the health board. We have got an agreement in place to open up additional beds at Glanreed in the Angelson Clinic. We will be opening up additional beds at Ysbyty Cwm Cynnon in Mountain Ash, and we will be opening up additional beds at Ysbyty George Thomas in Treorchy. That will net off the large proportion of the loss of beds that we've described. We are also progressing a contract to bring on additional theatre capacity and endoscopy room capacity because we've lost 6 theatres, or at the moment we have lost 6, 7, 8, 9 theatres on the Bridgend site. We have plans through the to reopen 2, but we are also leasing a private facility to continue some elective operating. So we're bringing aiming to get that in place in the first quarter of the new year in order to start treating patients. We're also working through a plan at this moment where we hope to be able to recommence inpatient orthopaedic surgery at the Royal Glamorgan this side of Christmas. But we're just working through the key enablers for that. We're also outsourcing a significant proportion of elective activity to local private hospitals, but also we're insourcing. I guess the sort of concluding remarks to the operational response has been to absolutely recognise the immense and amazing response of our staff. They have been extraordinary. People have willingly moved. We have teams who've moved from Bridgend up to Treorchy and have done so and embraced it. We've got teams. I was talking to 2 healthcare support workers who'd come over from PW and their surgical ward has moved over here to the Royal Glamorgan. I was talking to them last night, and they're absolutely, trying to look at how can we use this as an opportunity to move to a once CTM approach for all sorts of things. So it's been, through that adversity, people have shown their commitment to our patients, and it is, it's been absolutely fantastic. There's lots and lots of things to sort out, but that commitment has been absolutely fantastic.
Thank you, Catherine. Sally, I'll bring you in at this point. I know that you and the team were working with colleagues at very significant pace in order to get the business case conversations and submission sorted, because obviously this is a significant area of expenditure for which Welsh Government is providing almost all the cover for. I'm just wondering, any sort of perspective that you want to add at this point?
No, just to note a bit like Gethin, my thanks to the Capital, which is team and Estates team, but Capital in particular is a very small team, and Tim Burns's leadership as well in this, in terms of getting a business case approved that would normally have taken probably 12 to 18 months to get designed and approved. We succeeded in doing that in a sort of 4-week period, which just shows how much work went into getting it. I think you referenced earlier, Jonathan, how do we find ourselves here? In part, just like to address that one slightly, which is when we took on the Bridgend estate, or when CTM was created and Bridgend became part of our health board, there was already some significant backlog maintenance. There is across our estate. So just for people's awareness, and I know PPF has seen this in a recent paper, our current backlog maintenance, excluding Prince Charles ground and first floor, which, as you know, is part of a huge redevelopment scheme, stands at around 108 million. We get a discretionary allocation of around 8 to 10. It's been varying over the last few years, million each year, with which to address a range of things, digital, but also backlog and stat compliance. So there is a huge challenge within our estate that is inherent, and you'll also recognise that over recent years costs have escalated significantly within this sector following on from COVID and some worldwide shortages. So the cost of the backlog has increased, as well as the backlog being an issue that we've got that we need to tackle in a sort of risk assessed way. In the earlier surveys, this roof issue was not one that was flagged as at the extreme level that it is. The reason that it wasn't was we hadn't done intrusive surveys. You don't tend to do intrusive surveys of roofs because they cause more problems by taking off tiles. But when the tiles came off, it was apparent that the lack of ventilation had led to the roof battens rotting in situ, probably over the whole 40 years that it's been on there. But that was not visible to us before that. In fact, I think specialist estates have even noted that there was no visible sagging that would have given us the idea that this was an issue we needed to face. So in terms of our colleagues in specialist estates and in Welsh Government capital, they've recognised that this is an issue of extreme urgency, reflects similar to RAC concrete in its potential impact, and hence why we have moved forward with the business case so quickly. You'll also note, and just for reassurance to everyone, that a huge amount of work is now going on site. There's a large amount of scaffolding going on, and at this point everything is on track in terms of the timeline for this business case. But other than that, happy to take questions.
Thanks, Sally. That's really, really helpful. And again, appreciate the speed at which both capital and estates team have worked to to deliver this. And as you said, a very speedy submission, but obviously required, bearing in mind the severity and importance of this. Patsy, I'll come to you first. Thank you.
Yeah, I mean, just to add to huge congratulations to everybody. I've been involved in this kind of work myself and know how long it normally takes. And as Sally says, it's a process that takes ages. My questions are around the capital spending. Sally, I was really pleased to see the Welsh Government have requested the solar panels be installed at the same time as the new roof, which is a really good thing, obviously. But I wonder then how that will elongate the timetable and how we'll hit the CRL, the capital resource limit for this financial year. And are we confident that we can get everything, the remaining stuff, completed then, including the solar panels, within the next financial year? So it's going to be a bit of a juggling act this year, isn't it, to hit a CRL that is how long a bit of string?
Yeah, I mean it's obviously a large scheme coming in later in the year. There is a day-by-day programme set out within the within Tim Burns's office and capital planning to ensure that they're tracking this really, really closely. The expectation at the moment is that we expend 16 million of the 27 this year. However, we will work that through with them, and we don't have to fix the position until the end of January. And so we'll continue to work with them really closely around that. This inclusion of the solar panels does not impact the programme in as much as it won't require, we'll be able to reoccupy in the timeline originally expected. There may be some works that extend beyond the the deadline as set, which we've got it set at the 31st of July currently, but those will not impact or not intended to impact on the reoccupation of the building. Those will be external.
Thanks, Sally.
Especially, thank you, Sally. Okay, comments and questions. Yeah, Dilys, thank you.
I went to switch my microphone on. Everybody knows how impressed I am by the way this incident has been dealt with by all staff at all levels. But the bit that interested me in this report is the very last point, which says carry out a learning review following the internal critical incident.
Yeah.
And from what Sally was saying about the budget for maintenance, etc., what I'd like to be assured of as a board member is that there will be work done to identify whether or not we could face another critical incident like this and how our maintenance is going to be dealt with in the future.
Thanks. So I'll bring Paul in now. So I think there's two things here which are obviously linked. The first bit is looking back, okay, and I think it is important for us to learn from this particular experience as a board. And I've given that commitment to the cabinet secretary. But the other point about what we know about the rest of our estate, I think, is also important. So I'll bring Paul back on this.
Thanks. So yes, just to pick up what John's just said, Gareth's doing a bit of work at the moment just to do a sort of look back in terms of what reports have happened over the years, where have they gone, what happened when we fought in Bridgend patch over 2019. Because there's something about just understanding the sequencing of events that led to that point. So Gareth's going to sort of do that from a sort of governance perspective. We also did a because we were running as gold sort of command structure, we've done a learning event of that process as well. So what worked well, what didn't work so well. I have to say, I think actually it worked really effectively, the structure we put in place, and certainly the silver cells, we had specific cells looking at different issues. So one cell looking at discharge, another cell looking at facilities issue, another cell looking at workforce and others. So that model's worked really well. And then I think, as you just highlighted, Dilys, there's what does this tell us about other risks that we might have? And I think, Sally's talked there about the capital allocation we have, which frankly, is pretty poor for the scale of estate challenge we have, but that's the same with everybody in the NHS in Wales. One of the questions I've been asked a number of times is, and how do we make sure that we don't have similar problems in similar facilities across our sites? And I'm sure, I don't know, Sally, if you want to come in on that, but we will no doubt do a little bit of a stock take as to are we at risk, or was it a particular circumstance due to the particular way in which the POW facility was built? I don't know, Sally, if you wanted to add anything.
Yeah, so there are a couple of things. If I deal with POW first, so a couple of issues there, which was it came in to our health board, and our team is largely led by the old Cwmtaf team, if you like, if we will call it that. And we have had some difficulty in retaining estates head of on the POW site. It's an issue there where we've had quite a lot of churn. The documentation that came across to us didn't include all the detailed plans. They're probably in paper form somewhere, but we haven't yet been able to locate them, although people are still looking for them. So we do have the surveys and we do have some detailed knowledge, but since it came into the health board, we did have, we had issues around how the fire alarms worked, some of the electrical systems and other areas, which have led to quite significant capital investment. But, there is probably an issue around, do we have the full structural knowledge of how it was built? When we look at RGH, our next our next site, many of my team were involved in the build of that. They do understand it. There are regular surveys and they know how long each piece of infrastructure has to run. And that's very much in their risks sense. That's not to say we have the money to deal with it, because we obviously have a capital resource limit, which we cannot exceed, which is why, and we have to deal with digital and service change within that sum as well. We do bid quite regularly and get more than our I'm going to call it fair share, but I mean more than our population share in terms of what's called EFAB, or Estates Finance Advisory Board, Funding Advisory Board funding, where that's targeted around infrastructure, electrical, fire compartmentation and other issues. So we've been very successful in bidding for that over recent years. If we go to Prince Charles, we know Prince Charles is subject to what is a £300 million improvement scheme. It's a different sort of construction, so it's not pitched roofs in the same way, but we are well aware of what's going on there. It's been extensively surveyed. There are still issues arising as we do the works, because we find asbestos that hasn't necessarily been tracked from the start, but you can only find that as you go in and you manage it in the correct way with all the right approvals and processes in place. So there's a wider bit about how do we understand our estate. Princess of Wales, I think in particular, we did not understand that there wasn't ventilation in the roof. You would have expected there to be ventilation as part of the construction. It was also a shallow pitch and an inadequate overlap. That is what's led to this problem. I'm sure there will be guidance coming out across the NHS estate in Wales for people to do additional checks to confirm that they haven't got the same issue. It does appear to be something to do with the timing of when it was built and what was put in place then. And I think the other point that is different to some of our other sites is, of course, there was no solid slab between the roof and the wards underneath, which is what led to us having to take the action to decant out of the hospital, because there was only a suspended ceiling. So it's all about how do we understand our estate and our risks. I think in general we've got quite a good tracking and surveying approach, and my team update each year, but this one was associated with an unknown factor due to the construction of the roof.
So Helen.
Thanks, Jonathan. Just a quick question, which was about Paul's answer to Dillis's question and our board development session, which we have next month, where we're looking at priorities for the future and how that work will feed into the session that we're having next month.
Yeah, well, we can, once we've done that little bit of work, we can bring that back and either into that session or another form. Yeah, absolutely.
Thanks very much. Thank you.
Yeah, and when we discussed the Princess of Wales before, we discussed the schedule, a potential schedule of when things could be done and so on, when we can start moving people in. How are we in terms of meeting that schedule? Are we still on target?
Yeah, so the priority since to return to Princess of Wales is maternity and neonatal. So that we are aiming to return to POW in mid-January. What we are then doing is looking at all the other services that have moved and evaluating all of those service changes. We know that because of the additional work that we're carrying out at the same time in the operating theatres, because we're dealing with the fire compartmentation issues, replacing air handling units and a number of other capital and some electrical works in theatres, we know theatres will not be operational until probably August. And so the majority of the surgical services, the changes related to surgical services will have to remain as is until that point. So we are evaluating all of those changes. And then, as part of, we're just transitioning the silver now from managing the incident to now planning the redirection of the second half of the plan. So that's underway.
Thank you. Any other comments or questions to Gethin, Paul or Sally? I think just one of the outputs from this, and going back to the reference earlier to the look back that Gareth's going to do, I think that's really important for that listening, that learning bit for us as an organisation. From an assurance point of view, I think we then need to think about what else do we need to know about the quality of our estate more generally. And that's difficult because that requires, getting people to do that piece of work. And Sally rightly said that people in the capital team are very well versed, for example, in RGH, because many of them were there at the time in which that was constructed. But we do own a significant number of properties, which from an insurance point of view, I think as chair, I would value knowing a lot more about in terms of what is the state of our estate. I know we have talked in the past about having a plan for managing that estate in the future. You know, what it is that we keep, what we use, what if we do keep what we've got, how do we use that to better improve the services that we deliver to people. So at the same time as we have all those conversations around, you know, the excitement and the innovation around digital technologies and doing things differently in the way care is delivered, you know, estates are a key enabler. Well, I think at some point we will need to be clearer as an organisation as to what is it, A, that we've got, and B, what do we keep, and how do we use it. But I think certainly from the risk point of view, I think at an assurance level, I think it will be useful to consider how we have more information to the board that helps us to be more assured about the range of buildings that we've currently got. Just so, and I know that that's quite a big piece of work potentially, but I think, you know, if anything, I think that's one thing that I would draw out of the experience that we've encountered with POW.
So I would agree, Chair. Interestingly, we've just been on the investment board meeting about the LHP, and one of the questions was, if you have this resource, what's that going to mean to your other facilities in terms of, you know, we want to obviously invest in new things, but we also want to see it, the acknowledgement was from Welsh Government, we're not very good at closing things, and we're not very good at taking capacity out that is not fit for purpose. So I think it's going to be something we need to better describe. A couple of things, I guess, is the estate and the facility should follow the clinical model, not the other way around. I think historically we've tended to try and shoehorn services into existing facilities that weren't always the best place for them, but they were the place that had a bit of space. So we thought, oh, well, we'll try and have a go at doing that. So I think it's got to be done alongside the clinical services plan that we know we need to be moving on. I think also, I take your point now about the risk, and I think maybe, I don't know what you think, Sally, but we've got a very clear risk log and backlog state of all the buildings, and it may be perhaps that we could use a board briefing session just to update all board members, so everyone's aware of where the key backlog risks are across all of our sites, because it's not just 3 DGH sites clearly that are there. We've got a plethora of community facilities and other places which frankly are really not great, and we need to be getting ourselves out of, ideally. And as you rightly say, John, digital technology is an enabler to that as well. So I think, that would be a really perhaps a useful opportunity for a conversation at a future development session. And Sally might want to come in.
Paul. Sally, thank you.
Yeah, no, I absolutely agree. It's really important that the service model drives the estate. And if we think about the work we're doing around LHP, we're looking really at how models might work differently, and therefore the estate needs to be shaped around that. I think the only other thing to note from the meeting we've just come from is probably that they were clear that if investment is going into a large scale scheme like LHP, that will limit investment available elsewhere. But we are also aware that we are likely to see an increase in our discretionary allocation, capital allocation for next year, which is largely where we fund maintenance from, and that there will be a extension of what's called the EFAB schemes, which focus, as you know, around maintenance, etc., so that there'll be more money to bid for. The reasons why that is helpful is that there's a central pot that funds 70% of the work, where we fund 30% from our discretionary. So we are already looking at how we will focus around that once the announcements are formally made.
Right, so that's really helpful. Thank you, Stuart, and then Kenneth.
And just building on the digital points, obviously the opportunity of rethinking how we deliver services, but also just to state, and perhaps it is the obvious, but some of our aging estate as well, the maintenance and the retrofitting to maintain those is more expensive actually, because the legacy buildings that don't have the kind of modern sort of fit out that we would expect to be able to keep our infrastructure current, so we end up paying more. So I think it really welcome the opportunity to review that estate.
And I also think we should underestimate the staff employee experience of, if you have staff who work in good purpose clinical facilities where they know they can do the best service for their patients, it's much, it's really fulfilling as a job. Whereas I've been around many of our estate and I see some of our staff working in facilities that are really not great, either for the patient or indeed for the staff. You know, and I'm always amazed how tolerant staff are of working with, you know, people box and cocks. You see people perched in the corner with a, you know, they've boxed, and it's just not great. It's not a great experience for staff either. So there's also, we shouldn't underestimate the staff good feeling, if you like, of working in an environment that is fit for purpose and enables them to do the best for their patients.
Just one very quick comment, if I may, Chair. And I think this was part of the learning from the debrief we had, was I think resetting what our level of expectation is. I think it's fair to say a lot of people accepted, you know, POW leaked, and I think we've got to get to a point where that level of acceptance is, you know, we reset that bar because it isn't acceptable when a hospital leaks, and therefore we really do have to change that.
Absolutely. Thanks, Kath.
Yeah, just going to go back to what Sally was saying about the new funding pot, that it does include mental health, I think, and our mental health estate is a really high risk for us. So I just wanted to emphasise the need around mental health.
And I think, yes, Sally, I was saying earlier in your absence and Paul and Gethin's and Linda's, that we'll have the board development session in December. Obviously, there's an opportunity there for us to start shaping the conversation around our priorities. And I think we have to have that conversation in the mix of that as well.
Yeah.
Okay, if there are no further questions or comments on this, can I just, the board will just note the update. I think certainly my intention is, as we go through into next year, I think it would be useful just to keep this as a standing item on the agenda, just to allow a formal update to the board as to how progress is being secured. But you know, in terms of the timescale, I really appreciate how hard people are working now to deliver this. You know, and originally we thought it would be a lot longer than doing this by the end of July. So I'm very conscious that we'll move things back in as and when it's safe and appropriate to do so. So it's amazing to see this being done at quite considerable. I know that Linda isn't back with us yet. However, as the rest of the exec team are here, I'm proposing now to deal with the integrated performance dashboard, the first part, in terms of our overall performance targets, and I'll come to the finance bit after that, Sally. So, Gethin, can I come to you first, just in terms of the operational performance? I know we've had some update from Paul in terms of where we've seen improvement in those performance metrics. Obviously, I've reported those back to the Cabinet Secretary in our recent chairs and ministerial assurance meeting as well. Thanks.
Lovely. Thank you, Chair. I'm taking the paper as read, but just drawing out a few key things for the board. So Paul's touched on the continued improvement in CAMS and the de-escalation. So I won't say any more on that. In terms of urgent care, we had a good presentation from Ross Whitehead, the ambulance commissioner, at PPF, focused on RED performance and the response times. We had a good debate with him in committee around some of the actions that we are taking, but absolutely understanding some of the actions that WAST need to take as well to ensure that our population, because actually if you draw the data, whilst there is some correlation between our improved handover and improved response, it's not comparable with other health boards. So we remain with some of the lowest response time. It's partly related to our geography, but it is, you know, if you for example, if you look at Swansea Bay, where they have, you know, significant delays of handing over crews, their RED response is some of the best in Wales. So there is something about understanding what the ambulance service response is to that. But again, yeah, absolutely owning our responsibilities on ensuring that we hand over crews in a timely way. Our urgent care services clearly are impacted by the POW critical incident, but it is pleasing to see that we have sustained an increasing trend on 4-hour performance within our emergency departments, and actually are holding steady on the reduction of 12-hour delays within our sites, which you know, in spite of those service changes, is really positive. We started yesterday the launch of the stamp programme, which we've rolled out at Prince Charles. That's now was launched at Royal Glamorgan and will be going live for the reset fortnight in December. So again, really trying to focus on that approach of how we manage urgent care pathways as effectively as we can. In terms then of diagnostic weights, I think it's really important to draw out the fantastic improvement that's been achieved there across nearly all our modalities. We've got some of, we're improving significantly our waiting times across both imaging and endoscopy, with some very focused activity now on our neurophysiology service and our cystoscopy service. So again, we remain confident that we will deliver the 0 patients waiting over 8 weeks by the end of the financial year, which is which I think is a real improvement to our patients in ensuring they get really timely access to the diagnostics is key. Massive thanks. We've had the temporary MR on the LHP site. We've cleared the backlog there. We've now got the CT scanner, which we've extended, and again seeing our CT weights reduce and our non-obstetric ultrasound volumes reduce. So massive thank you to our colleagues in diagnostic services. It is important to flag that there is a risk because we've lost capacity in endoscopy. So whilst we're trying to manage that with our existing estate, whilst we wait for the mobile facilities to be delivered and go live, there is a risk that our endoscopy capacity, that our performance might oscillate as we work through that. Just in terms of cancer, Paul touched on cancer. Our performance for September was 56.5. As of this morning, we've got 1 day until validated data. But our performance this morning was at 60.7%, which is the highest it's been for probably 3 years. It's really, and it's about the sustainable change we've made to pathways, which is what we focused on. Rather than chasing some numbers, we've looked at real sustainable change to our pathway. But drawing out within that, I think we have to recognise the huge change and improvement in breast services. So breast services in September was 78.7%. That was the highest performing by about 15% of all the breast services in Wales. When you think back to 2 years ago, we had a 26-week wait for an urgent breast appointment. And I think we can't underestimate. This is about how teams work. It is about having the capacity, but actually, testament to Zoe and Sally's focus of creating the hub at the Snowdrop Centre. It just shows that actually giving staff the right tools to do the job gets the best results for our patients. And so, it is really important to recognise that. From an RTT perspective, you'll see our numbers have gone up in month. That is a real risk area for us. So we made a request to Welsh Government for just over £12 million of support for RTT. We've been given 7.5 of that 12, and which we are utilising to with the independent sector to both outsource and insource as well as our own capacity. But we have got a finite capacity challenge. So whilst we were on course to deliver 0104s by year end, that undoubtedly leaves us with risk now. And the key risk specialty for us is arthroplasty surgery and orthopaedics. So that's hip and knee replacements. We just cannot buy the capacity we need to deliver those. And I think just drawing out funds, the follow-up's not booked. So we have, because we've had to step down a range of specialties during the critical incident, they have been focused, particularly in ophthalmology and orthopaedics, on clearing their follow-up not booked backlog. So recognising those numbers remain high, we are seeing some real improvement in that data now in months. So I'm hoping that will follow through in the next couple of months worth of the performance report, where we will have reduced that volume of patients. But I won't, that may be the key points I wanted to raise. Happy to take some questions.
Thanks, Gethin, much appreciated. I'll just ask other exec colleagues just to perhaps focus on their areas first before I come back to board members to ask questions. So, Richie, can I come to you next? Just Deputy Nursing. Thank you.
Sure, thank you, Chair. So just first to take you through the infection prevention control slides and some of the data there. So you'll notice in relation to IPC, starting off with Clostridioides difficile, we are above where we want to be in relation to this year. You can see from the data that there's a particular focus around community elements in relation to this bacterium. And that's certainly been our focus. And up until now, we've struggled with that based on the resource that we've had within our infection prevention control team and the previous lack in relation to strategy. We know that this year the board approved the strategy for the next 3 years, and associated with that is the workforce element in terms of the team, and actually working closely with Philip from public health as well as to how we look at this problem. It's going to be multifaceted, and there's elements here as well of prescribing that we know of, but we need to first of all look at what the data is telling us. If we go through and look at other bacteria here mentioned, so MRSA, we are below where we were last year, which is a positive sign, as well as for MSSA. From an E. coli perspective, again, we were worried about this last year, and essentially we would seek to reduce the number further, but it's promising to see that we are below where we were last year. And we know that, particularly in relation to this organism, it's primarily through from fecal to oral transmission, and the community prevalence here is high. So we're looking really at a public health approach in relation to how we tackle this. So further engagement between infection prevention control and our public health colleagues. Klebsiella and Staphylococcus are reassuringly below where we were last year. But again, all of this is formulating into a collaborative approach into how we manage some of these organisms, particularly with the community prevalence being so dominant in the data that we see. In relation then to looking at safe services, so from a never events perspective and nationally reportable incidents. So our national reportable incidents, as you know, we've been on a bit of a journey with this. We've had a backlog over the last several months. Some of that's being attributed to key areas such as maternity, ophthalmology, and we are now starting to see reductions in relation to certain areas, ophthalmology being one of them. There's been a particular focus awarded to that discipline with teams working through the harm reviews, and we're starting to see that come to a conclusion. That said, we are still seeing some delays in relation to the nationally reportable incidents around closure. So this month, I've commissioned a thematic review of the processes to understand what the blockers are and where some of the enablers are, so we can actually understand what's going on. Some of this will be the fact that we require clinicians' time, both nursing, AHP and medicines, in order to contribute, and they're battling with that in relation to them providing clinical services. But we need to understand now what's going on to see how we can relieve some of those processes. But overall, I think you can be assured that there's the relative scrutiny in relation to the numbers and the processes, certainly from an executive perspective on a weekly basis, but the team's looking at this data daily throughout the week as well. So from a complaints perspective, concerns, we're on a good trajectory here and sustained. We know that we went through probably the beginning of, the end of last year, we were starting to make some changes in relation to our process. We had some concerns, particularly in relation to our response within 30 working days. But we've seen now more than several data points of sustained performance, and with that, with workforce issues as well. So we know that the process is resilient in relation to some of the fluctuations we see around workforce issues. We have, of late as well, had additional engagement with Clive's colleagues as well as the Ombudsman, where we've had some difficulties in relation to processes internally. So we've reflected on that. We've engaged both with the Ombudsman and Clive's colleagues as well to look at how do our processes currently function and where were we getting it wrong? What were we getting right in relation to that? Some of that was down to single points of failure or it designed into our systems, and therefore we've addressed that, as well as improving some working relationships. But overall, I think just want the board to understand that from our perspective, we consider this to be a much more improved process with good engagement from the team, and therefore seeing sustained improved performance around concerned responses. I think at that point, I might hand over to Dom and Charlton.
Certainly. Thanks, Rich. Tom, if you can.
Let's briefly say what we did that time. So we've talked about this before, so I'm not going to go reiterate the points that we've done from the previous. Well, the path to setting up the mortality board, which successful aspects to it. The one area that's, I've probably got more concern about than the others now is our mortality review process. Just from the number of clinicians who are engaged in doing it. Again, like Richard said, it requires clinicians time to do it, but also they have to be engaged and want to do it. It's an extra aspect. The other thing that just to flag, I'm expecting, as I think we all are, going into that season, what actually will rise again. Can't get off because it goes. Part of that is obviously to do with just the sheer number of viruses that are out there at the moment for the population. Despite very good efforts on the vaccination team's part, vaccination rates have remained very low, and that obviously puts our vulnerable population at much higher risk. Sadly, that's both our staff and community rates are quite low, subscribers. And that's all I really was to say. And you'll be able to feedback hopefully better than this board had.
Thank you. I'll pick up on that. But
thank you.
Thank you. That's a very articulate description. But I mean, as Dom's just said, I mean, vaccine rates are not where we would want them. We are broadly in line with the rest of Wales in terms of our adult vaccination rates. However, they are low, both within community, over 65s, vulnerable populations, and staff. I mean, staff both within the health board, but also within care settings as well. There is notable fatigue in terms of people taking up vaccines, but there's also work underway in terms of communication, putting on mop-up clinics, etc. For children, we are doing very well with regard to MMR. So MMR, 90% of pupils are reported back with 2 MMRs at this stage. Again, influenza vaccination, we're in line with other health boards, but below where we would like to be. We're bolstering it. We actually took a decision at ELG this Monday to reinforce the nursery vaccination with 5 additional nurses for 3 weeks. There has been calls on health visitors, for example, and so that's made delivery complicated, but we are picking that up. We are improving communication with schools, and we are developing e-consent, because at the moment we're using paper consent, and that's very inefficient, really. Yes, children are being denied vaccine because someone hasn't signed a slip, as opposed to just pressing yes on the phone. So I mean, so vaccination isn't where we want to be, but there are plans in place to improve it. And we, in terms of smoking cessation, I have to say, we met the 5% target, exceeded the 5% target, and are looking to increase capacity in the smoking cessation services. Obviously, with the tobacco and vapes bill that's come out, there is increased emphasis banning of disposable vapes, for example, which are having an effect, as well as increased emphasis in terms of enforcement of non-smoking in public areas, which we envisage would lead to an additional chance of people keen to give up smoking until we should provide the support to them. Thanks, Chair. Excellent. Lauren, thank you.
Thank you. So I'll just add a little bit of additional narrative in terms of some of the professions that I'm accountable for. So within psychological services, within mental health, you'll see that our weights, the performance of the weights under 26 weeks is above our trajectory, which is good, but still below where we want it to be. Just to highlight some of the work that the team's been doing, so they've been working with HIW and secured some funding to train up over 100 members of the care group to increase skills and confidence in psychologically informed care, psychologically skilled care, and enhanced psychological practice, which is great. The team are also piloting an intensive treatment for complex PTSD, and then they'll evaluate that compared to outcomes with when people are in service for, they're seeing less frequency, but are in service much longer. And they're also increasing the group delivery of psychological therapies within local primary mental health services and in CAMS. So there's some great work happening there to look at what alternative models they could use. Audiology, you'll see that there's a gradual reducing weights over the last 12 months. And there's been some good practice there with the teams sharing waiting lists across sites and upskilling different teams in different skills. And just a heads up, in autumn 25, we'll be reporting all of our audiology waiting lists into Welsh Government, whereas currently it's only the adult 14-week RTTs. So the teams are focusing on those. Gethin's already acknowledged the great work happening in diagnostics, so just to pass on the thanks to everybody involved in that. And within therapies, it's the continued picture of increased demand and increased complexity. So the teams are continually looking at how we can deliver services differently, opportunities to innovate in response to that. And I guess what doesn't really come across through the IPD is the amount of work happening within primary and community care to try to transform how we support people in those settings.
Excellent. Okay. Howell, can I come to you next in terms of the workforce update, and then I'll throw it open to colleagues for questions.
Yeah, sure. Just a couple of things quickly to highlight. So you recall that I mentioned sickness was stabilizing to pre-COVID levels. That continues. And if you look at page 26 of the performance report, you'll see that that continues to follow the same trajectory. That's page 198 of the bundle. And around about the 6.7% mark. So while that's stabilized, the pre-COVID levels are still high. And we always were traditionally high as a health board. So we're just trying to do some further work to understand that. A positive picture as well on nursing turnover in particular. So you recall that reached a high of around about 13% towards the tail end of last year. That has kind of stabilized around about the 8.6 mark. So our target in terms of pre-COVID levels is 8.65. We're at 8.69. Just in terms of the 3 DGH sites, they have all now dropped under 7% for nursing turnover, which is a very different place to where we were a year or so ago. The lowest turnover is in our POW site. But yeah, they've all dropped below the 7% mark. So some really positive signs there. I don't think we can claim that that's down to all of our actions because turnover is such a dynamic indicator. There is some good stuff happening there around some of the work that care groups are doing individually and nursing teams, but also some of the process work around the lateral move scheme, etc. So we'll keep an eye on that and continue to track it and try and find out what's causing that reduction. And of course, we continue then to build into our workforce planning assumptions some of our age profiling, and we'll keep an eye on that as well. The only other thing I was just going to mention was around Stataman training and PDR compliance. So again, I'm looking at page 28 of the report, page 200 of the bundle. You'll see that just slow, steady trajectory upwards over the last sort of 4 years, really, since the beginning of the pandemic, when we had a significant drop off on both of those. We are stubbornly underneath the target for Stataman training. I'm just hopeful that we can just push that a little bit further just to get ourselves above the target. But again, just to commend care group colleagues there, because that's a really difficult thing to do amongst all the pressures that colleagues are dealing with. And you'll notice in a couple of the graphs there, you see a drop off around the December-January time 2 years ago, but we seem to have avoided that drop off in December and January, just last December and January, which is good. So we'll obviously keep an eye on this month and next month just to see where we are on that. And again, on PDR, we're now up to, I think, around about the 66% mark, which isn't quite where we'd like to be, but we were traditionally around about the 40% mark, so a significant improvement. And hopefully the process changes that we've made there in terms of the revised and much more straightforward, hopefully, PDR process will help that to increase. And we are doing some work around team PDRs as well, just to try and make it easier for busy ward managers who might have 100 or so staff to do a PDR for, just to check in on a more regular basis, which seems at better odds with the evidence that exists around efficacy of PDRs. So those are probably the only things I wanted to touch on, Jonathan.
Thank you, Harold. Much appreciated. Linda, did you want to? Was anything from your perspective? And I know usually we come to you from an overview, but yeah, okay, thanks.
No, there is one of those top level, the top 15. We are looking to split one. We haven't managed to do it yet.
Okay. Just before I throw it into questions, Gethin touched on the the huge improvement we're seeing in our in breast services. I'm just wondering, Sally Bolt, from your perspective, any reflections that you want to add at this point? I know we've seen quite significant improvement in terms of how we are ensuring that we're delivering a much quicker service to the patients with suspected breast cancer. And I'm just wondering, anything from your point of view?
I think it's the fact we were able to centralise that one precious resource all on one site. So whereas before there were clinics happening on the RGH site and some happening in East Talbot, and actually clinics were happening at the same time, which meant that if somebody was on annual leave, there wasn't anybody ready to cover because they were geographically separate and they were already doing something elsewhere. And plus, because as radiologists, we have other commitments as well. So we're not just with dealing with the breast cancer, whereas the surgeons are sort of more targeted for that. So as well as working together, we've also really engaged with sort of role diversification. So we've got consultant radiographers, our trainee consultant radiographer. We've got a breast clinician who's now training in the radiology aspect. So it's to make sure that we're broadening the team as well, rather than just the old traditional roles. And I think that but the fact we're all able to work together means that we can cross cover. I can I can do the wise on that day, and it's really helped. And also looking at new technologies and other additions as well. So new techniques for localizing the impact of breast cancers, which can take some of the time to it. Whereas traditionally you'd need to ally the radiologist time with the surgeon and the theatre slot time. Now we can separate that reliance because there are new technologies we can utilise, which makes it much more streamlined for the patients, and it's sort of more resistant, more robust, and you're less reliant on if somebody goes off sick or whatever, then there isn't a massive scramble to find somebody else so that the patient can still have their operation because it's all set up prior. So I think all sorts of things that we've done to enable us to have such a significant improvement.
That's it. Thanks, Lily. That's great. Okay. Quite a lot in here. So before I bring colleagues in, I'll just bring Paul in at this point.
Yeah, no, I was just going to put on the 104-week waits because obviously Gethin highlighted the risks we're sitting with, and I guess Gethin the other bit which was a big risk in that is the cataract activity, which, as colleagues will know, is being managed through the regional programme of work. And we had an update a couple of days ago from AB, who are sort of leading on that process, to say that they've been successful in securing quite a large volume of activity now in independent provision for cataracts, which will hopefully give us a better shout of getting to our ambition of clearing the cataract 104s by the end of the year. But that side, I still think we just need to be really cognizant of and keep a close eye on the other risk, given it is such a high priority from government and from the Cabinet Secretary in terms of delivery of the 104 trajectory. I mean, the message has been very clear that you've committed to deliver a trajectory, it needs to be delivered. We have made the point that if you want us to deliver it, there are some enabling resources that are going to be needed given where we are. But I think we just need to be, as a board, very alert to the risks that sit around that.
Sure. Thanks. I'll just mention on a slightly different subject. So I just wanted to mention staff survey.
Yep.
So today, I think we're around about the 23% mark for staff survey. So you recall that last year we reached a total, I think, of 18% response rate. So I think all things considered, when you think about what's been going on here the last few weeks, to got to at this point with a day left, a 5% increase in uptick is really good. That has sort of bucked the trend across Wales. So most health boards have seen a reduction, and at the moment, I say, because Cardiff and Vale are kind of nipping at our heels, and we change between first and second every day at the minute. We have got the highest response rate of any of the health boards in Wales. What that does enable us to do, because of the suppressions on the data, is get really good local level directorate data so that we can work with care group teams and obviously corporately, just to make sure that we provide a really good detailed response to the survey and take some really clear actions. But I think that's a real positive for us.
That's really good to know, Hal, and congrats to you and the team for the amount of effort that's been put into this. Engaging directly with staff through the care teams, face to face, through our comms led by Simon. It's been a collective effort to try and persuade and support people to participate in the survey. The speed at which we can respond to the data in front of us is really important, because I know the frustration last time of not getting the official response back from HRW was really quite frustrating. I don't know the reasons behind that, but we want to make sure that we are using this information to good effect. So when people say, we think this, we can then demonstrate how we use that information in response by trying to address the things that they raise with us. I think we can only build confidence if we can demonstrate that we're attempting at least to act on the sorts of things people are saying.
Yeah, and I think we've had a much better experience, I'd say, this time around in fairness to HRW colleagues, and we're expecting the data in January. We had it in May last year, so that's a massive improvement. But I also just want to touch on some of the really good examples out in the care groups of the engagement that's been done with staff, both on last year's survey results, but also encouraging this year, and a particular mention, I think, to therapies colleagues as well, which has been fantastic.
Fantastic. Okay, that's really good. Thanks for the update, Hal. Okay, questions on the performance report? Dennis.
Not a question, really, another statement from me. It's about the increase in the percentage of the staff and mandatory training. I mean, I remember having figures as low as something like 27% at one point on this. So congratulations on all the work that's been done on there, and really good results for the staff survey. I remember the depression in the room last year that we'd only reached 18%, although we had increased. But yeah, really good results on staff on the staff survey as well.
Thanks.
Let's hope they've been kind to us.
Absolutely. Ian and then Kath. Thank you.
Yeah, I'm going to fly the flag for digital, which you'll be surprised at. But
what's digital?
Digital, yeah. we often say that digital will improve efficiencies and so on. And there's a graph in here which just starkly jumps out if you look at it, how that happens. If there's a page, effective services clinical coding written on it, if you look at that graph of our performance going from 2020 up to now, we were bouncing around 40 to 50%. We're up now over 90% in terms of performance. And that's because of digital efficiencies that we introduced. So I just say that. And leave it there.
Very well put, Ian. Very well put. I don't think anyone's going to disagree with you. Kath.
Yeah, I had two questions, I suppose. One was around the ADHD ASD assessments, and whether we can start looking at taking any different approaches, noting that we've got vacancies in staffing, but is there a way of getting other people to do assessments in around the multidisciplinary team? How do we move, because obviously our targets are pretty low at the moment. We've got long waiting lists and target of 80%. And the second question was around discharges and how we're really working, with the local authorities. The top two seem to be assessment issues and the care home placements. When are we going to be looking at the market assessments around care homes? when I go out to local authorities, they seem to have a slightly different view from us. So how do we align our views around what the real issues are and how we move forward? And I know it's a thorny issue, but noting from here, we're kind of bottom of the list at the moment around discharges when we compare ourselves to other health boards as well. So it's just something I think we've got to keep looking at. And I know there's lots of work going on, but it's just how do we get more alignment with our local authority partners and work closer together to try and solve that. So those are my 2 questions, please.
Thanks. Just perhaps if we deal with the hospital discharge bit first. Gethin, in answering this, could you also touch on the progress being made around the recruitment of their support workers? I know we are really ambitious around the CTM hospital at home scheme, and that will fit into the conversation we have in December around what we are going to do collectively to boost our community capacity to support people closer to where they live. But also, I know in the update that you provided to me ahead of my meeting with the Cabinet Secretary, you talked about some of the focus work that was done on those people waiting 21 days. And the work being done there to really address, sadly, those people who've been waiting, quite a significant period of time.
So part of the work we did on the back of the critical incident, touched on, we set up 3 cells, one of which was focused on discharge, and we had really good engagement from our local authority colleagues and really making sure that we were really clear on the actual next steps for every single patient, and some very focused work to make sure that all the delay codes were accurate, that the patients were exactly as we were describing them. And on the back of that, then we've then done some very focused work on what we call our super stranded patients. So they're patients who have waited over 20, who have been in hospital for more than 21 days. And last week so this panel meets regularly, and it's got members of staff from both the health board and from our local authority colleagues. And last week we discharged 5 patients who collectively had a length of stay of 982 days. So there are, and what that's helping us understand are where there are specific gaps in the market for very complex patients. So patients with significant neurological challenges and other things. So we're trying to eat the elephant a bit in chunks, if I'm honest, Kat. So there's this macro level, but actually as you get under it's understanding. So clearly we know that getting patients home with supportive care is the first thing, and CTM hospital at home is going to be part of the solution to augment the provision that's already there, and particularly focused on those patients where we think we can reduce their ongoing requirement. So we've been out to recruitment. We've had 200 applicants to work in that service. So that we're going through an interview process now. So there's going to be a whole day interview process where we're going to try and process all of those. So that's really exciting that there's that level of interest and in those posts. And I think then, Linda, did you want to come on to the the sort of market assessment?
Yeah, I mean, I suppose just to augment that answer. I mean, obviously, the reason we've just signed up this morning to an MOU is for that longer term strategic approach to this. And in the meantime, let's be honest, the local authority is in a position where it's always a little bit of a tussle, isn't it? It's always a bit of a push-pull. There's a letter from the WLGA this week saying that the local authorities across Wales are facing a deficit of 560 million.
Yeah.
They need an uplift of 7% in order to just stand still. So let's not be naive about the kind of dynamics in the system in terms of where they're at and their ability to respond. It just, in terms of us being at the lowest rate, I know that that's because RCT is the lowest of the local authorities, and they recently did the shift, didn't they, where they've outsourced rather than in-house their some of their dom care, and that did create a big dip, which as I can see the numbers recovering, and we're hearing from the local authority that has stabilised, so that we should see those figures improve, and then this initiative that Gethin's talking about should also give us a step change in terms of those discharges. In terms of the longer term and the market sustainability, we actually are in fact prioritising tomorrow a discussion with the local authorities about as we move into this work together, we need seems to be the phrase of the week, our demand and capacity needs to be aligned in terms of what we're expecting for all sorts of services. And we're sitting at a point when our city is consulting on closing 2 care homes where there's a large proportion of dementia beds, and we have expressed our concern about that. My confidence that there'll be a plan that matches our demands. It's not. I'm not that confident, but our task is just to use all of the influences that we've got to flag that, to work with the local authorities, to ensure that they are accessing the care that's there. We know there's also some care beds that are deemed too expensive, and when you're working with that sort of deficit, we can sympathise, but we can't tolerate.
And we did. We were Lisa was there with me at the adults board this week. We talked to Lisa about the commissioning, sort of how we approach that commissioning agenda together, so that actually we avoid the scenario where we make a decision about some health older people's beds, and then a local authority does something different around their own beds. So we said we need to have a combined response, and also a combined response to how we tackle the challenge of the fees and things. So at the minute, we've got 3 sets of fees across our patch. So each local authority is a separate fee level. They pay to different nursing or residential homes. So what can we do together to try and standardise that? But we also recognise, as Linda's just highlighted, is that there's a massive risk because with some of the recent changes in the budget, that's going to put additional funding pressures on social care providers. So I can anticipate things like fee requests for next year are going to be quite significant when you look at some of the pressures some of those providers are under now. So even more important that we try and work together to sort of have a collective response to that.
Linda and Paul have covered a lot of what I was going to say. I suppose to give the board a reassurance, there are conversations going on with the local authorities, and we're very much in a sort of space of working together. There was a really helpful dialogue last Friday at our I forget what all these meetings are called, but our leadership team, when we met face to face, and they were some of the issues that were raised, particularly around discharge. RCT obviously has affected our figures because they're looking to outsource the dom care service, and obviously in the process of looking at the consultation around closing the homes. So that has impacted on some of the discharge figures, and obviously the situation with Prince of Wales Hospital didn't help either because we had to move people at pace, and so some people just remained in hospital. So there's a lot of dialogue going on at the moment. There are pressures with regards to budget. We agreed last Friday that there would be a piece of work because there is some funding through the RPB around that care home piece of work. So that's going to be done at speed, I think, before the end of the financial year. So that's something we've got certainly for the fees next year. And Linda's touched on it. We've got another meeting tomorrow to look at that community offer and how we can work together as local authority and health board.
Thanks, Lisa.
Thanks, yeah.
Okay, any questions? Just a couple of quick points.
Pick up the neurodiversity.
Oh,
Did you?
sorry.
Yeah, so we have secured some additional money to support the service. So we're going through a redesign of the team and making sure that we are having the right. It's quite a traditional model, and we're changing that model, but we are focused that, and that will bring our. I think we're anticipating that our longest wait will be down to around 75 weeks, and continuing to reduce that further. So but there is a big focus piece going on.
Yeah, so there's a post that's on this to look at. And in fact, it's a really successful programme. Maybe we should do more of a deep brief on that, because it's all about how it is that 2,000 people, more than we expected, ended up on the list in short order.
Yeah.
How it is that the education system is requiring diagnoses, what it is that the families actually really need.
Yeah, absolutely. It'd be really interesting to have that. Thanks.
If I just go back to the performance in cancer, and just to look at the rather notable improvement in terms of our performance in hitting, attempting to hit that 60% target on the single cancer pathway. Yeah, that is a noticeable shift, and getting to that point where we hit that 60% target as we're required to by the end of the year, and 70% by the end of March, it will be a really big achievement for our health board. And I think recognizing that there is a significant increase in demand for diagnosis and obviously treatment support, that demand is not ebbing away. It's going to increase. So on the one hand, whilst we've got the pressure of delivering a service response here, it's also tells me the importance of what we're doing externally with government and with our partners around the public health response, because we can't just, like with everything else, Philip, I know he's gone into the corner, like with everything else, we can't just be about dealing with the consequences of what we see. We have to be in that space of working with others to try and deal with the issues of demand at the other end. But a real noticeable shift, Gethin. I think we should be, congratulating all of our teams. And I know we've seen improvement across the tumour sites as well in terms of the way in which colleagues are working to address these weights. On diagnostics, can I say a huge congratulations to the team? I mean, if you just look at the data, okay, on that target of having diagnostic tests done within an 8-week period, this time last year we had almost 11,000 people waiting. Okay, it's now under 3,800. That is a colossal shift within a 12-month period. Now, obviously, we need to maintain and continue to improve our performance, obviously. But when we describe the challenges that we face as a health board, and I know we're nowhere near where we need to be in terms of that 52 weight in outpatients and the 104-week weight as well. But there's amazing work going on here, which shows you how things in different parts of our system are improving continuously. Sometimes it feels slow and it's bit by bit, but we are securing noticeable improvements in our performance. And I don't want that getting lost in the narrative around some of the big challenges that we also face, because we can't ignore the big challenges, but I think it's also right that we articulate how collectively our teams are working in order to secure some really quite remarkable performance improvement. And I think it is worth us just reflecting on that. One bit that I think is sometimes difficult to explain, and maybe we'll come back to this again in the board development session, around the conversation around developing primary community care. What does that hospital at home mean for people? What do we mean when we describe doing things differently for people closer to where they live? And going back to Lauren's point earlier around the data that we collect and the data in front of us, and very often what we struggle to do is probably to articulate the impact that our colleagues have working out in the community, working in primary care, but working in the community closer to where people live. And sometimes because of the way in which our metrics are geared mostly towards secondary care, it's hard for us to describe, maybe it's hard for us to understand in totality the real impact that our colleagues have out in the community. And I think we need to think about that. And if nobody at a national level is going to design a suite of indicators or metrics that will be of use, maybe we need to decide what it is that we might need to know going forward if we're going to start to reshape some of those community services, because the metrics, or qualitative and quantitative, probably aren't there anyway. But we'll need to think about that if we're going to be thinking about how we design some of those local-based services.
Yeah, I would agree, Chair. And this is what we have done. We've established a primary community transformation board within the health board, because we felt, and I chair that group, and it was to really bring together much of the work that's already going on in different places to really enhance and develop our community services, but also to put a bit of an internal challenge in to say, if we're serious about, developing the services in our communities as an alternative to hospital, we've got to perhaps think a bit more creatively about how we do that. We've got to bring our GP colleagues along with us, because they're all dealing with some massive pressures anyway. And, we're not going to be able to resolve the long-term ambitions that we've got if we don't deal with some of the short-term pressures that primary care are dealing with. So one of the questions we talked about in that session this week actually was outcomes and how we're going to measure impact. So maybe what we could do from that group is start to just sort of pull out a few key measures that group feel not just tracks what's the efficiency of the service we've got today, but also how are we tracking things like the capacity that we're moving out of hospital into community. I mean, it's interesting, isn't it? We suddenly move towards out of POW into a community setting literally overnight. And actually, I think many of those staff feel that actually it's probably a more appropriate facility for some of those patients to be cared for because it's a non-acute, quieter, more sort of suitable environment. So it just shows you that actually sometimes you need to introduce that bit of a shift. So, but measures such as that may be the things we start to count, and as you say, create our own rather than waiting for someone else to tell us what they think we should be counting.
Thanks, Paul. Okay. Right, so we note the performance update report. Thank you very much. Right, what we're going to do is we are going to take a slight comfort break of 5 minutes. So it'll be quite brutal. All right, I'll make it 10 minutes. I'm being generous. It's almost Christmas. No, I'll do 10. I'll do 10. Right, so just to let you the handling of this, just so colleagues are aware as to where we are, because for anybody who at the end of this meeting will have the pleasure of watching our proceedings online once the recorded version is up. But the health warning will be that people should not be using the published agenda as a guide, because as we all know, it's been a little bit all over the place. So what we will do when we return after a 10-minute break, we'll do the finance update from Sally. We're then going to return back to 5.5 on the planning maturity matrix from Linda. We will then return back to Sally for the capital update report, which sort of then almost brings things to a conclusion, I think. But I'm getting slightly lost. I'm sorry, the INC and the winter plan. So, like I said,
I promise to be free.
I said almost everything to a conclusion. Right, 10 minutes to be back in your seats by 12:10. That'd be fantastic. Thank you very much. Okay, well, welcome back. Just to confirm how the agenda will run between now and the end of the meeting, just so colleagues are aware of the order in which I'm going to take things. I'm going to come to Sally as Finance Director next, just to deal with the finance report under 6.2 and also the capital report under 6.3. So Sally can deal with both of those items separately, but at least one will follow the other as they are actually on the agenda in that way. I will then come to Linda to return to 5.5 under the planning maturity matrix, and also then to deal with item 7.1, which is the integrated medium term plan. And finally, last but certainly